So why we're here today is to provide support for suicide prevention and build an infrastructure to help students at risk for mental health, substance abuse, and suicide attempts.
Our focus is on training, and we believe that the school systems are responsible for meeting certain needs pertaining to their students' challenges, and particularly those needs that affect their ability to perform successfully academically. So while we can't address all of their issues, we do believe that by educating campus community members and creating a competent community, we can help students be successful at school.
We believe that everyone on campus should be able to take care of each other, to provide an initial response if they see something. It's the see something, say something model. And then know how to pass on the person with a warm handoff to the right person next to get additional assistance. And on campus specifically, suicide is the second leading cause of death among 18 to 24-year-olds. For the first time ever, the rates have gone up nationally for suicide. This is not that different in college campuses. In college campuses, it has been traditionally the second leading cause of death, with anywhere from 1 to about 10,000 students dying by suicide a year.
Every year.
It's also individuals who are on campus who may be at risk. There's individuals who are thinking about killing themselves. Anywhere from studies are showing us from 6% to about a third of campus students have thought about killing themselves. And the attempts are 1 to 5%. So for every about 50 to 200 attempts, somebody dies by suicide. And this gives us an opportunity to intervene with our students who are on campus.
Bringing the conversation specifically back to Monmouth University, the Counseling Center typically receives about 800 referrals a year, and we determine, based on the presenting situation, the presenting problem, whether or not the student needs to be stabilized with additional support, and we work with local agencies. So last year, 22 students had to be transported to the hospital for stabilization. Interestingly, of those 22 students, 13 of them actually needed to be hospitalized. These are important statistics because it speaks to Monmouth's system, which is significantly different than that of other schools. From the moment the student is accompanied to the hospital, we're working on re-entry. Most schools don't do that. They ask the students to go, get their care, and when they're ready to return, to come back. We're involved in that process, and we really try very hard to get the students back. In fact, of the 13 students that were hospitalized, 9 of them were able to return and actually concluded the semester successfully. The 4 that did not return either chose not to right then because they decided that it was important for them to prioritize their mental health, or because they actually needed longer-term care. However, at any point, those students can come back, and we will obviously provide them with some support.
And Franco, this is so important because what we know then is individuals are on campus who may be at risk. Importantly as well is that we need to let our students know that we're not going to kick them out of school if they need to have support and services. That we work very hard in Franco's office and other offices work really hard to keep them on campus, and which we know actually staying on campus and being connected with the university is actually a protective factor.
Right. The statistics that we're speaking about are individuals who have disclosed or have been referred to us. But the truth of the matter is, and what we're trying to reduce is stigma around mental health and campus mental health in particular. There are many more students who have not been identified who would benefit from services.
So as part of being a Monmouth member of the Monmouth community and a Hawks Fly Together community, we want you to make sure you understand what suicide risk is on campus. Identify not just the risk and the warning signs, but the protective factors that we want to build on campus to keep people here. And then, of course, if there is somebody who you're concerned about, again, upstream, before there's a crisis, we want you to know the resources and the referral processes so you can get individuals the help they need. So what we thought was important is that you get a little sense about what an individual who's thinking about suicide might be feeling. Because it really provides us an opportunity, if we do this early enough, for an upstream intervention approach. And
there are some characteristics that everyone can kind of keep in mind. And one of them is that if a person is moving into suicidal ideation, suicide is seen as an alternative to what may appear to be an unsolvable problem.
Typically, suicide is characterized by ambivalence. They don't know whether they want to live or die. They just want this pain to stop or the message to be shown. And this is something we need to work with earlier before they get into crisis mode.
Right.
This black and white thinking where there's this tunnel vision where it gets narrower and narrower in terms of options.
I think the fact that the thinking at that point is also crisis thinking is really important, because we're not going to be able to have a lot of conversation with the person who is in crisis. In fact, we talk about a suicidal crisis because we're not really programmed to take our own lives. So clearly at that point, someone is having grave difficulty in really thinking and processing in a logical manner, and they're not seeing solutions. So if we only have access to the person at the moment of crisis, we're just going to have to take those steps that will keep the person safe. We can't engage them. One of the characteristics is that suicide sometimes is considered to be a means of communication. Again, with an absence of alternatives, it feels as if it's the only option left.
So if we move upstream, we'll be able to do more work in getting individuals help they need and keeping them stable in the community at Monmouth.
Right.
This is a sign from an evidence-based program called Lifelines. And it is showing you this traffic light that shows you a sort of a little mnemonic thing that we can start to think about, is that we're going to talk about green, which is protective factors, yellow, which are risk factors, and then red, which are warning signs.
So when we're in a situation that's green, I liken it to how you feel when you're driving and you hit a traffic light and it's green, and what does that feel like internally? You don't feel tight, you don't feel tense, you don't feel stressed out, you just keep driving. But if you stop and think about the way your body feels with a yellow, when the light turns yellow, you'll notice that you actually start to feel a little bit different. And if the light turns red, you've got to make some decisions pretty quickly, and your body will feel differently. We would suggest to you that you notice those things also in terms of the communication that occurs between people. As a person starts to share more information that might be indicative of a crisis mode or moving into a crisis, you're going to start to feel differently. And by acknowledging those changes in the way you feel at that moment, you'll be able to make decisions about what you need to do next. Green is the baseline. Green is go. Green is okay. Yellow is when you start to notice changes. We do this every day. We don't necessarily think about it consciously, but if you bring it into your conscious awareness, you have an expectation about how your friends, your students in the classroom, your family members will behave when you see them. If I run into Michelle while we're walking across campus, and I have an expectation about how she's going to respond to me when I say hello. And if she doesn't respond in that typical way, there's a change, I'm going to regulate my response accordingly, and I'll probably say, what's wrong? Right. What's going on? Because I'll pick up that signal, I'll feel it. So the baseline is hugely important in this whole conversation, because we all have the ability to notice this slight change. So the traffic light model, the green, yellow, red, and the baseline. There's a shift, there's a change in behavior. It may be very slight, but it may be very important. So there are protective factors that come into play when we look at mental health, and we encourage you to just kind of glance at them. And again, they have transferable value. They're in place. They exist across the lifespan. One of them has to do with establishing close relationships with caring individuals. In this case, where as we speak to faculty and referring to students in the classroom, you don't know who you are for that student. You may be the caring adult.
Absolutely.
You may be the mentor that the student will come to and share some information with. So that's one of the protective factors. Being connected also to a university, to a group of some sort, has protective value. So for example, students who are loners, who don't associate with clubs, who rarely get involved, and their risk factors will be increased by nature of the fact that they are not as connected. So connection has protective value. A good sense of self-esteem and good coping skills that we call reasons for living. Right. A reason to be around. We ask these things in counseling when people are talking about suicide or enter into suicidal ideation. What would keep you from doing it? Those are reasons for living. And access to care. Our students have access to care for medical issues, for psychological issues, even for issues related to substance abuse. It's available. At Monmouth, it's actually in their comprehensive fee, so there's no charge. Also, protective factors come from cultural and religious beliefs, and we have different organizations on campus. And some of those groups will discourage suicide and promote self-preservation, and that definitely has protective value. It's a protective factor. And of course, what we want to do, because there may be some groups who see suicide as a noble expression of a value, of a belief. However, what we want to do is really encourage the help-seeking behavior and help people see that they can think things through.
We don't want to normalize that suicide is okay.
Right.
What we want to do is make help-seeking okay.
Right.
We want to move this upstream. And these green factors is what we want to promote on campus. We want to keep these strong. While we have this great green, there's going to be yellow. And what you'll see is that these are risk factors. And with risk factors, it's important to know that you're going to see a long list in a minute. That long list, you're going to see a lot of people. But one risk factor doesn't make a suicidal ideation, attempt, or completion.
Right.
It's really this likelihood that the more of these risk factors you have, or somebody demonstrates or is exhibiting, then the risk increases, and we need to be worried, and we need to then take action. Because at yellow, this is that upstream area we really want to try to intervene in. If you see some of these things, and you start to see many, and you start to feel, this doesn't feel right anymore, and your students leaving your office and you're still worrying about them, it's time to make that call to Dr. Mancini.
So some of the risk factors involved, and again, these are across the lifespan. They'll present slightly differently depending on the individual's age, but the demographic, the population that the student belongs to, the female statistics. We know that the incidence of completed suicides is higher for males within a certain age group. Males tend to use more lethal means, and that's why they tend to have more completed suicides than women. The psychiatric history is very important. We always inquire about that. Drug, alcohol abuse, also previous suicide attempts, hugely important because it's one of the markers for another potential action.
Right, because it becomes a coping skill. It becomes part of their toolkit as a resource, and we don't want that to happen. But if it's there, those three things, the previous attempt, the family history, or that exposure to somebody else's suicide, makes it more palpable.
We don't know people's histories. We don't know how an individual's suicide is going to affect not only the close person, the people that are close to the individual, but also the people that are in the immediate environment.
But as a faculty member, whatever department you're in, you may be seeing it in their writings. You may be seeing it in something about their disclosure that they've made to you. And if you have that information, it's just a little bit more information that you keep in your baseline. Right? So if you know this about this person, and then something else happens, you might be a little bit more in tune faster.
Also, experience of stressful life events. And there are different levels of resiliency, so then we pull in personality factors because some people are just resilient. They bounce back even under incredible duress. Right. And others seem to be more challenged by that. So kind of observing, being alert to the differences, and we go back again to baseline because a faculty member also has an expectation how a first-year class is going to behave, or a group of seniors is going to behave, how they're going to respond to perhaps constructive criticism, to a poor grade. That baseline is for the group. Then you have individual baselines for the student based on your contact with the student.
And same with coaches. Coaches, advisors, individuals have experience with their students, and you know when times are stressful, you know midterms, finals, it's stressful, but you add some of these other things, and if you see a big change that's different than the baseline for this group, it's really time to act. You don't wait till get to red. We need to act in the yellow.
Right.
And that access to means is really important around here.
Absolutely, absolutely. We've had situations that are a little bit different. When we think about access to means, we think about the different ways in which students might act on their suicidal ideation. And while frequently people think about, oh, well, you know, an overdose of pills or perhaps a violent measure such as using a gun or firearm, whatever the case may be, we really encourage you to think very broadly about access. The train, for example, train tracks, those are means. Where we live, where the university is located, those are means. The ocean, it's means to an end. The jetties, a lot of our students commute. And so again, you have to really broaden your idea of what means is and be willing to ask some questions. The other thing I wanted to mention was about physical illness, and I think that we don't necessarily realize how this impacts psychologically. Chronic illness can lead to depression, will lead to depression. Think about how you feel when you have a crummy cold. So the student who has chronic medical issues is also a high-risk individual. We are not asking you to do anything other than to pay attention to what you see every day.
Right.
This is all observable. If you start to notice a pattern, that's really the opportunity to intervene and speak with somebody.
Yeah, and I think that's exactly the point, is that if you start to see many of these things, you see several of them together, then you need to be even more concerned, because there's no one single risk factor. It actually tends to be a perfect storm.
Between 18 and 24, for many, many university students, it's the first time that we see a serious mental health breakdown. It's the first time that a serious mental health issue presents. So it's an opportunity to intervene, but it's also when we might see some serious issues that hadn't presented before. So we need to pay attention. Again, going back to our campus, though, to Monmouth University, we ask students to identify different issues when they come in. They do a symptom checklist, and we look at what they wind up actually disclosing in the counseling session itself. But interestingly, there are some statistics that are consistent nationwide. So for us, during that year, academic issues were about 28-30%. They came in identifying the academic piece as a concern. Adjustment issues that we tend to think is so prevalent is not necessarily what the students identify as prevalent. They don't necessarily associate the way they're feeling, particularly during that freshman year, to a transitional piece. So it's important to consider that. The anxiety and depression are written in red, and they're also the highest numbers. And anxiety is close to 70%, was close to 70% last year. Depression getting close to 50%. Very importantly, these statistics, and we'll continue down the list, they're consistent with the statistics nationwide. What we've noticed nationwide is that there's a spike in the level of anxiety that students are presenting with when they come into the counseling center. And certainly we're moving towards 50% of the population that actually makes contact with us that talks about feeling depressed and actually having symptoms of depression.
But I think the key thing here, which is a real risk factor, and the literature consistently shows that it's depression and anxiety that really rises that risk for suicide, and those comorbidity, them happening together. But those depression and anxiety are things that we can treat.
Yes.
Right. As we move to the red, this is actually a national mnemonic. On the right-hand side here, it says, is path warm? You kind of have to read it up and down. I is ideation, thoughts, comments, anything. I'm not going to be here next semester. Really, where are you going? What's going on for you next semester? Because it may be a veiled threat. Right? And then even somebody just saying something like that needs to be followed up on. And then it has the depression, anxiety, and substance we kind of talked about already. It has substance use, but anxiety, anger, depression. And when we talk about two things, we talk about imploding and exploding. And imploding is that drawn, helpless, hapless, and hopeless.
In addition to the traffic light, in addition to the baseline, another takeaway is the 3 H's, helpless, hapless, hopeless. Any of those signs, worthy of attention. Start to take a closer look at what's happening.
And that hopeless is, I can't do this, there's nothing there, there's nothing for me in the future, I have no future, there's nothing going on, I'm not going to make it anymore, I can't succeed, I can't ever do well. Versus helpless, I can't do anything about it. I can't, there's no solution.
That feeling that you get when you're sitting with a student and you're trying to problem solve and solution find, and they're just not giving you anything. They've kind of given up everything.
And I think the hapless thing is something we all feel.
The emotional vampire.
The emotional vampire. It sucks the energy out of you when you're sitting with somebody who is depressed and helpless.
Yeah, and they're kind of flat.
Their eyes are flat. Their tone is flat. Their emotion is flat. They're quiet. And they're not participating, and they're not talking, and they're flat.
They're not engaging.
Not engaging with anybody.
Yeah.
So that would be that depression, hapless. But the exploding is just as concerning. It's that anger, irritability, recklessness, physicality of just out of control that is just as bad. It's this change, whatever that change is for you from that baseline.
Sure.
Right? What exactly is a faculty member going to see?
They're so valuable in this whole puzzle, putting all the pieces together, because they're seeing students in different situations with respect to the ones we see. There's a lot of cues and clues, really, in a classroom.
And one of those first reactions is just talk to the student.
Exactly.
We're not running to call you right away.
No, absolutely.
First thing to do is to talk to them, and we're going to give you some strategies about what you might be able to say and do when you see some of the performance cues, which is just part of your job as a faculty
member. And some of
member.
These we've actually covered.
Right.
For example, the emotional distress, the student who just emotes. all the time, or the student who never emotes and now is emoting, and that's something to pay attention to. Right. The angry outbursts, Dr. Scott mentioned them, withdrawal from activities, can't finish a group project, can't engage with the group, having difficulty even communicating with the group, feeling helpless, hopeless, this is it, this was my last chance, I don't know what I'm going to do, I will be here next semester, if I fail this class, I'm not quite sure what's, or even I'm going to kill myself. Anxiety, irritability. Very importantly, sometimes there's a tendency to, if a peer expresses concern, to not necessarily take that immediately into consideration. Our belief is that peers have information that we don't, the same way that faculty have information that we don't. So if peers start to express concern about a student, that warrants some investigation. So that's another important factor that can play out in the classroom.
Right. And then physical cues,
yeah,
right?
Yeah.
These are a little harder to see as a faculty
right.
member, but it's really that baseline to a change. So if
right.
you're seeing any of these things, this is when you want to react.
For example, deterioration in their hygiene, which is a huge giveaway. And what we know about mental illness is that one of the first things that happens is that people start to neglect themselves a little bit. Weight, appetite, fatigue, exhaustion, always tired, nodding off in class. Real hard one, noticeable cuts and bruises. We as a society have difficulty in approaching someone and saying, I've noticed that. And we're going to give you some language in terms of how do you approach a person and not get pushed
right.
away. But we have some difficulty. The thing that starts to happen in our mind is this really any of my business? We believe that it is. Right. And we would encourage you to believe the same. We talked a little bit about chronic illness. Obviously, disorganized speech, slurred speech, that could be a lot of different things. It could be drugs or alcohol. It could be a serious medical problem, and that has played out. So never jump to conclusions, right. Never make assumptions, approach the student and discuss things.
And we have here like inability to make eye contact,
right.
but you have to be very cognizant of cultural
absolutely, yeah.
competency
right.
and not making an assumption just because somebody's not making eye contact that it's a problem. And when we see this, we have to have some options of what to do as faculty. There needs to be a solution that we can do. And what I often hear is really, are we allowed to do this, Franca? Aren't we worried about FERPA?
Well, yes, we are worried about FERPA. However, there's a clause in FERPA as far as crises are concerned. It is not a violation to contact the appropriate individual that can help solve that particular problem with the student. Right. What we hear a lot is conversation about confidentiality. Right. And I think this is an important clarification to make, because on campus, the only offices that are bound by confidentiality and privileged communication are counseling and psychological services and health services, and clergy if they're doing counseling. We're bound by our licenses to confidentiality. Everyone else really has a duty to report.
Now, Franca, though, there are people on campus that are professional counselors. Mm-hmm. There are social work licenses mm-hmm. and counseling mm-hmm. individuals that have licenses, mm-hmm. but that's not their job on campus.
Mm-hmm. It's interesting that you bring that up, Michelle, because it comes up frequently mm-hmm. where a situation kind of gets out of hand and the faculty member might say, well, but I have a license. That's fabulous because the faculty will have great insight and perhaps understand the behavior that's being observed. However, everyone has to work within the specific role for which they've been hired. Right. And therefore, the fact that a faculty member has a clinical license and may even have a practice outside of campus is not applicable to this situation.
Because they're their professor.
Exactly.
They're their teacher.
They're there as their
or their
teachers.
Advisor.
Exactly.
Right.
So we expect them then to reach out to the appropriate individuals.
So when we're trying to put a picture together to get somebody help and assistance, we need all the pieces of the puzzle to get the full picture, right?
Absolutely.
And the faculty are going to have a unique experience in the classroom, coaches and administrators, advisors, food service, facilities,
area coordinators, residential life has a huge role.
Life. We all have a huge role on campus that we can add a component, as well as the students themselves, about their peers. So what do we do?
Well, you talk to the student. Once you've identified a problem, we encourage you to talk to your students. Talk to them appropriately, talk to them outside of class, try to create an appointment, a moment when that's not squeezed in between other situations and where there's a certain degree of privacy. Listen. Active listening is huge. Know your limitations, as you just brought up, with regard to what you can and can't do.
And I also think, though, with the limitations, not everybody's going to feel comfortable
That's
with
a good
this.
point, yeah.
And you might have your own history that when you see a student or you see somebody in distress, it may bring up your own emotional stuff, that things that have happened in your life or your prior exposures. And that's really important to know. Maybe it's time for me to bring somebody in early and have the conversation together, right?
Right, and be alert to, due to your own discomfort, not letting something slip that you really think should be investigated.
Right.
Again, we're asking you to transfer the information, turn it over, but that's going to involve a little bit of conversation on your part with the student. In order to pass it on, you need to know your resources and be able to contact them appropriately. When you're addressing the student, one of the things, as I mentioned, was to meet privately. Express what you've concerned. What did you observe? You noticed that the student nodded off. You noticed that the performance has changed. You've noticed that they made a couple of comments in an essay.
And it's important to note that this slide's green.
Yes.
Because we're rolling back to that traffic light model. And when we start as faculty getting into a situation that we get nervous, we need to know what to do all the time so that when we get nervous and anxious, we always still fall back on the baseline.
Right. And this is helpful.
And the green.
Because it's really a checklist that could be used in any situation, not only with the student in crisis. But be very specific about what you've observed. It's not an open, endless conversation. I brought you in for this reason. I noticed this and I am concerned about this. Use very open-ended questions when you do. Be non-judgmental. Very importantly, engage the student. Has this happened before, and what's been helpful in the past? What do you think would be helpful now? Pull them in. They have to be part of the solution, otherwise it's not going to work. Suggest a resource. Be careful again about broad statements about confidentiality. We're bringing this up again because people tend to say, it's okay, I won't say anything to anyone. You can't do that. You need to be honest and straightforward with the student.
Definitely coming up with a plan together and working together and having a follow-up appointment. Don't just let them go.
If it's not the only contact or not the only time that you've observed a problem, you may need to consult with a supervisor. Don't hold on to the information. Don't keep it private. That could be a mistake. Be sure that somebody else knows that you have a concern about this student.
When we're starting to get concerned, what kinds of things can we ask? Who can we talk to? How do we make that next transition? Who's that next warm handoff that we can have?
Well, you're always safe if you do use questions based on what you've observed. Legally, you're safe. You're not falling into any discriminatory issues or anything like that. You've observed something in the classroom, or you can use the term, I've observed that. You can use the term, it's come to my attention that, if by chance you get information from other sources. If you're in difficulty, call us. You can also turn to your immediate supervisor for some assistance. Of course, counseling and psych services, student services, judicial affairs, res life. Depending on the problem, depending on the particular situation, you'll make choices about who you might refer the student to. Health services in some instances, substance abuse, veteran services if you're dealing with a student who happens to be a veteran. And then, of course, faculty receive twice a semester the notice from the campus intervention team, which is made up of an interdisciplinary group of individuals, from faculty to health services to university council to the police, where we talk about at-risk students and try to see the best way to assist them and to support them.
And students might not be comfortable talking to you directly because you're their professor or you're their coach. You're somebody who's an authority to them and can impact their lives. And so it's okay to ask them that. If you don't have to talk to me, is there someone you're okay talking to? And then it doesn't have to be on you because they're not comfortable there. But remember that trusted adult? We want to get them connected back to that trusted adult.
The protective
and
factor.
It may be, you know, I had a student who said that, like, I don't want to really talk about it, I'm okay. And I said, that's fine, you don't have to talk to me. But do you have someone you have to, on campus you can talk to? Yes, and they were able to name somebody, so it made me feel better, and then I could follow up and just encourage them to talk to them. Or I've also called you, Franca, where, you know, I think we need to walk you over, right? And sometimes—
Which is totally acceptable, by the way. Faculty sometimes will walk a student to the office, and I would say to you, if you decide to do that, if you are going to walk a student over to counseling services, there's two phrases that are giveaway phrases for us. Amy Smith needs to make an appointment. We know it's not a crisis, but that the student needs to be seen.
Right.
Amy Smith needs to speak with the counselor. We know that we're going to do an emergency assessment. Very simple. We know if we can wait 24 hours or if we need to see the student right then. And as you know, Michelle, we do walk-in assessments on a regular basis. We never turn a student away. If they just come into schedule, that's fine. But a student who needs to talk to a counselor immediately on this campus will talk to a counselor immediately.
Do you think everybody knows where you are, Franca?
Well, I sure hope so. If we try hard
Where are
enough.
you?
Well, we're on the 3rd floor of the Student Center, which is fabulous because we're right in the center of campus. So we're really easy to get to. Yet we're private enough because we're upstairs on the 3rd floor that they don't feel intimidated by coming into the office.
Yeah. So you can make sure we know where people, when you can make a referral, it could be to Dr. Mancini,
Yep.
or it could be to psychology, to substance abuse or
Substance,
physical
health
health,
services,
or
yep.
anyone.
Yep.
But it's really important too that when you're in this yellow zone, we're back to yellow now, is students don't have to listen to you, do they?
No, and that's a problem
That is
because
a
the thing
problem.
is, you may feel that you've done absolutely everything right, and unless you know that there is imminent risk, not just I think the student has an issue, but there's really imminent risk, the student has expressed suicidal ideation, they may say, well, thanks for asking and thanks for giving me these suggestions, I'll think about it. It is absolutely their choice to make the decision. However, communicate that to us because we receive information from a number of sources and we may have a piece to the puzzle that you don't have and we may wind up reaching out to that student because it's one more piece and it's the piece that prompts action.
And it could be that they're afraid
Absolutely.
because they're afraid they're going to lose their scholarship or get
well,
kicked out.
you know, you have to listen to the student's fears.
Right.
But, you know, end the conversation in a way that the student knows that they'll be able to discuss it with you further and that there's actually an expectation that the conversation will continue. And maybe that follow-up appointment is going to be to say, you're doing great, which is what we all hope. But still, it indicates interest and involvement.
And while we really want to focus on the yellow and getting upstream and getting services early to maybe, again, not all the way to counseling service, maybe it's disability service or veterans affairs or something on campus that can provide support and structure. But when we get to red, we're in the emergency situation. And if you see something that's in an emergency situation, somebody is seriously considering suicide or they're expressing thoughts in the moment in an imminent way, you have to call the police.
Right. Call the police because they'll pull us in immediately. We work very closely with university police as well. I'll be the next phone call. However, if you're having a conversation with the student, as you've done on different occasions, Michelle, and they're willing to come with you, don't leave them alone. It actually is good to take the student out of that situation, get them out, get some deep breaths, take a short walk, and walk them to counseling if it's safe to do that. And then we'll pick up from there. Right. So you have a couple of options. You're going to have to make a couple of, make some decisions, ask a few questions. But certainly if there's any kind of medical necessity, you start with the police.
And when you say ask a few questions, what do you mean?
Well, if you have reason to believe that the type of crisis that the student is experiencing, if they are extremely agitated, they're giving you half sentences, they're not really clear in terms of what they're thinking, you will need to ask, are you thinking of hurting yourself? Which is easier for some people than saying, are you thinking of killing yourself? But you can soften that a little bit and you can say, for example, are you thinking of hurting yourself? Have you thought, and the student might say, well, no, I'm not. That's not enough. You need to ask the next question. Have you thought about it in the past? Because sometimes that next question will give you the information that will enable you to make the decision. Right. And one final question would be, have you ever attempted? The question of having attempted suicide is the main marker that we look for. If it's happened once, there is the potential that it will happen again. Right. So yeah, those couple of questions are really important.
These are the important numbers on campus. These are the phone numbers that you can call. And with Monmouth University Police, it's just 4444.
It's very easy, yes. Right. It's so easy to remember. If you're on campus, no matter where you are, no matter the time of day or night.
So I just want to thank you for spending some time with us. I hope you got some information out of this. I'm Michelle Scott from the School of Social Work.
And if you do have questions, give us a call. I'm Franca Mancini, and I look forward to hearing from you. Thank you.
Thank you.